ahead and move on to the fourth panel. Dr. Arambula.
Thank you very much, Mr. Chair. We will now move on to panel 4 on the proposal to require jails and county juvenile facilities to process Medi-Cal applications at the time of their release. We will have 5 speakers on this panel, including J.C. Cooper, Ned Resnikoff, Kathy Senderling McDonald, Dave Putnam, and Catherine Cohen. If we can please begin with J.C. Cooper.
1 second. As I'm rolling this up, one thing I would just flag is that we actually do have an acronym book at DHCS when you start here, and it is 65 pages long and I think growing. So definitely something we need to work on.
Well, you can send us a copy. We'd love to have it.
Except for it gets outdated about within a month because of how many new acronyms we apparently decide to add to our book every day. So just wanted to make note of that. Okay, so on this particular initiative, I'm going to highlight a few initiatives around the justice-involved population, just because I want to make sure we are linking them all here and then specifically answer the questions that you have. So there are multiple justice-involved initiatives, all with the proposed start date of January 2023. The one exception to the 2023 time period would be the transition of any of the whole person care services that are being provided, transitioning over effective January 1 of 22. But essentially, we are proposing to ensure that all inmates receive timely access to Medi-Cal services upon release from incarceration by proposing to mandate all inmates complete a Medi-Cal application prior to release from incarceration, as well as a mandate that jails and county juvenile facilities implement a process for facilitating referrals and linkages from institutions upon release. And that could be to county specialty mental health, it could be to drug Medi-Cal, DMC, ODS, or the Medi-Cal managed care plans, depending on what types of behavioral health services they were receiving while they were incarcerated. We think it's a critical coordination point that really needs to be implemented. Additionally, one of our enhanced care management mandated target populations is individuals transitioning from incarceration who have significant complex physical or behavioral health needs requiring immediate transition services to the community. I point that out because it's an important part of the other mandates within the proposal. I know we had mentioned those in previous hearings. We also have a variety of the eligibility criteria within the In lieu of services suite, which explicitly calls out people transitioning from incarceration. I think it's an important link just to make sure that we're thinking through this broadly and how important calAIM is for the justice-involved populations and the various touch points in which we're trying to think about both diversion as well as smooth reentry into the community to ensure that people can have the best health outcomes and the most success as they re-engage in the community. Many of those in lieu of services are focused around the housing pieces, recuperative care, and the short-term post-hospitalization pieces, just to flag a few. The other thing I would note is that we do plan on requesting approval to authorize federal Medicaid matching funds for Medicaid services being provided 30 days prior to release for eligible justice-involved populations. So this would include services like enhanced care management being able to start 30 days prior to release. That will allow for that coordination of services that are needed. It would also include some limited community-based clinical consultation of services provided via telehealth or e-consultation that could be done, as well as a 30-day supply of medications for use once they are released from incarceration so that they have that medication upon leaving the jail or prison. This request is under the authority provided via the Support Act and would allow us to draw down federal funds for those services. One of the pieces that we think is just so critical here is ensuring continuity of health coverage and care for the justice-involved populations is a real high priority for us here at DHCS, and I do know in California broadly. This group of low-income adults is disproportionately people of color who have considerable health care needs, but often who are without care and need medications upon release. I'm going to provide some information around statistics. Some 28.5% of male prisoners are Black, as compared to 5.6% of the state's adult male residents. For Latino men, the imprisonment rate is 1,016 per 100,000 as compared to the 314 per 100,000 men of other races. Individuals leaving incarceration are particularly at high risk of poor health outcomes. Justice-involved individuals experience higher rates of both physical and behavioral health diagnoses and are at a high risk for injury and death as a result of violence, overdose, and suicide, more than people who have never been incarcerated. Inmates who have a behavioral health disorder are more likely than those without to have a disorder to have been homeless in the year prior to incarceration, less likely to have been employed prior to arrest, and more likely to report a history of physical or sexual abuse. Nearly 70% of individuals reoffended within 3 years after release from prison. While the factors contributing to recidivism are complex, I think we could all acknowledge that, effective treatment for mental health conditions and substance use disorders can interrupt the cycle of reoffending. By working to ensure justice-involved populations have a stable network of healthcare services and supports upon discharge, DHCS strongly believes that it would be able to demonstrate a reduction of emergency department use, hospitalizations, and other medical expenses associated with relapse, as well as improvements in health outcomes, including the reduction of overdose rates and deaths. There's significant research out there that shows the number of people after being released from jail due to either not continuing medications that were expected or their high needs of medical services show up in emergency rooms and or admitted to the hospital within 6 months of being released into the community. If we can intervene earlier by ensuring they have access to Medi-Cal upon release and making sure there are clear coordination pieces for those individuals with complex physical and behavioral health conditions, we do think that we could greatly improve the outcomes for these individuals. In addition to some of the questions around pre-release application process, currently the majority of counties have a pre-release application process, but the process is not standardized and it is voluntary at this time. So it does vary county to county. Under our proposal, DHCS will standardize the county inmate pre-release policy and mandate it for all 58 counties. This will be coordinated effort with participation from county staff, the jails, and other county and state partners in order to make this successful, including our managed care plans as well in county behavioral health departments. Implementing the process in each county will vary depending on the collaboration the county has with justice-involved entities and associated contracts. Funding has not been identified for this component part of calAIM because of the implementation is planned for January 1 of 2023. DHCS plans to identify the required funding requirements in the 23-24 budget process. However, the department is also requesting from CMS to be able to draw down federal funds for the infrastructure and capacity building for the counties via an 1115 waiver. As we know, this will be a large lift statewide, but a very important and critical one. And so seeking those federal dollars for that is a critical component of what we are moving forward in. The mandate, the majority of Medi-Cal application processes upon release from jail or county juvenile facilities really builds on a lot of the lessons learned that we have had in the voluntary application process, as well as our whole person care pilots. We had a number of whole person care pilots who really worked closely with our county partners, the sheriff departments, and implemented really good programs across the state of California. Some examples include Kern, Kings, Los Angeles, Marin, Mendocino, San Joaquin, San Mateo, and Santa Cruz counties. The entity assisting with the application would vary by county as it currently does today. Some counties will use county hired care coordinators, others use county eligibility staff to assist, and others have contracted with community-based organizations or coordinators. We really want to allow for that flexibility because it's worked for counties today in regards to how they set this up. But look to engage with people about what the best standard is across where that variation can exist, and know there will be many conversations about this as we move forward. So look forward to answering questions when it is the appropriate time.
Thank you very much. Next, we will hear from Ned Resnikoff with the LAO.
Hello, this is Ned Resnikoff with the LAO again. Just a couple of brief comments about this proposal. We feel that the proposal does have merit and that it links back to the core mission of calAIM, that it would connect high-risk individuals with necessary services. However, there is some question of whether it could create a state mandate and what the cost of that would be. We're not prepared to say that it would create a state mandate, but it is something to potentially keep in mind. Thank you.
Thank you very much. Next, we will hear from Kathy Senderling McDonald, Executive Director of the County Welfare Directors Association.
Hi, thank you, Chairman and members. Kathy Senderling McDonald with the County Welfare Directors Association. For purposes of this panel, I'm also representing the California State Association of Counties, or CSAC. Sarah McDade-Ting from CSAC and I work together on these talking points. Counties strongly support policy linking inmates with behavioral health and healthcare plans upon their release. It's really the next logical step for this high-risk population and could improve outcomes for individuals, county systems, and our overall communities. For safety reasons, the sheriff must be able to retain the authority to approve or deny whether a non-sheriff entity may implement this policy at the local level. And we also ask, in developing trailer bill language on this topic, counties be given flexibility in the process that is used, as many counties have already voluntarily implemented Medi-Cal pre-release eligibility activities. So it's not necessarily a one-size-fits-all process. And we certainly think that the process envisioning taking the activities one step further that counties have already done with that warm handoff of eligible inmates to health and behavioral health plans upon release makes sense, and look forward to working in coordination with the department and other stakeholders to develop that process. Counties are also open to both county and non-county entities doing this work upon approval of the sheriff, but the chosen entity must be required to interface closely with county mental health plans, county human services eligibility staff, and other county departments and services as appropriate, as well as with the managed healthcare plans. County-level implementation efforts must include, at minimum, processes to submit applications to county human services agencies for eligibility determinations, as well as close communication with county mental health plans to ensure efficient linkages to the critical county-run services that the released inmates can benefit from. CWDA will be suggesting some language to ensure that the duties assigned by law to county human services agencies, namely conducting initial and ongoing eligibility determinations, remain clear and are clearly separated from the activity of supporting an individual to either fill out and or submit a completed application, which may be done by outside entities such as those contemplated by the calAIM proposal here. And in addition to the necessary funding to implement these new requirements, which we agree with the interpretation that they are mandates, counties are supportive of additional state funding to measure outcomes associated with this policy proposal, which could include perhaps increased receipt of services, prevention of post-incarceration overdose deaths, or other outcomes that we would want to see reduced, reduced recidivism, and other appropriate measures that the stakeholders may provide. I'd be happy to answer any questions. That concludes my formal remarks. Thank you.
Thank you. Next, we will hear from Dave Putnam, Assistant Sheriff in Kings County.
Well, thank you. Good afternoon, committee members. I think it is. We have reached afternoon. I first want to apologize for not having working video on this computer, and I hope you can hear me okay.
Yes, sir. Please continue.
Thank you. Just a brief introduction. My name is Dave Putnam. I'm the Assistant Sheriff for the Kings County Sheriff's Office. I've been employed with Kings County for about 31 years, with the last 10 years as the second in command of the agency. My pleasure to get to speak a brief overview on some of the issues on the sheriff's office as we move forward. In Kings County, we have a medium-sized jail. We're located in the Central Valley of California, right below Assemblymember Arambula's territory. In Hanford is our county seat. Our current inmate population capacity is about 637 inmates. Pre-COVID, our population was consistently over 600 and many times as high as 650. Now, in the midst of COVID protocols, we've been able to keep our population to an average of between 425 to 450 inmates daily. And I appreciate this opportunity to highlight some positive outcomes in what I believe have been an effective process within our facility. We, in a small county such as Kings, were able to effectively team up with the Human Services Agency, and we've done that again. And prior to COVID, we were able to embed an eligibility worker inside our facility. And this worker with the Human Services Agency, the eligibility worker, was provided with on a daily basis with a pending release report, both 30 days and 60 days out. And this process allowed the eligibility worker to review pending releases and determine which inmates may be able to reinitiate or initiate benefits upon release. And it was super effective. The auditing of this process, we didn't miss too many inmates that were eligible. So now with COVID, we've had to transition to a process of a video-based process in which the eligibility worker can communicate with the potentially eligible inmates. The inmates are provided with a tablet and can communicate with the eligibility worker that way to review. And this eligibility worker is still provided with release reports and the ability to communicate with the inmates pending release and to provide them with an application and assist them with applying for benefits. And I just wanted to articulate some concerns going forward as we continue to advocate for a consistent, streamlined process. And it's been a good system working closely with our county human services agency. But the concern from a sheriff's office standpoint, I think, is that we miss some inmates, or if the process isn't smooth and streamlined and consistent, that some eligible inmates upon release may fall through the cracks. And that's the biggest concern, is that there's always a flux of population. So I just wanted to express that concern, and I'd be happy to answer any questions that have to do with the Kings County Sheriff's Office. Thank you for your time.
Thank you, sir. And I'm familiar with Hanford. I used to work at the Adventist Emergency Department that's there in Hanford. Next, we will hear Catherine Cohen, who is the staff attorney at the National Health Law Program. Please begin.
Hello, thank you. Good afternoon, and thank you for the opportunity to testify today. My name is Catherine Cohen, and I'm an attorney with the National Health Law Program, which advocates, educates, and litigates to protect and advance the health and civil rights of low-income and underserved populations. We are glad to see that DHCS is taking efforts to ensure that individuals leaving incarceration are connected with low-cost health coverage and services in a timely manner. Justice-involved populations have high health needs, as has been mentioned, particularly behavioral health and substance use disorder needs, and Medi-Cal coverage is essential to achieving continuity of care, better post-release health outcomes, and to reduce recidivism. NHELP supports the calAIM proposal to require a mandatory Medi-Cal application process for individuals being released from jails and juvenile facilities. However, we make the following recommendations to ensure that the goals of this proposal are realized. First, the state must adopt a Medi-Cal suspension rather than termination policy for all incarcerated individuals, regardless of how long they are incarcerated. Currently, California law requires Medi-Cal to be terminated after 1 year of inmate status, and this limit on suspension remains intact in the current trailer bill language. NHELP recommends that suspension not be time limited, and instead that Medi-Cal remain suspended for the entire period of incarceration for all individuals. CMS has been clear that states can and should suspend rather than terminate Medicaid for incarcerated individuals, and has noted that suspension provides for continuity of care. In addition, the 2018 Support Act, which has been discussed today, already requires suspension for juveniles in detention facilities and former foster youth up to age 26. The Act also requires that states conduct a redetermination of eligibility prior to release without requiring a new Medicaid application. While the calAIM proposal mentions the desire to leverage the Support Act, it fails to state if or how DHCS is meeting these current obligations under federal law. We recommend that the state implement open-ended suspension for all individuals who are incarcerated, including those in state prisons. This will reduce confusion, create consistent policies, and make the system easier to implement. Otherwise, counties and facilities will be required to determine for each individual if they are covered by the Support Act and process people through two different sets of rules. Such an approach is burdensome and is not sound policy. Second, we endorse DHCS's proposal to help incarcerated individuals enroll in Medi-Cal prior to their release and recommend that this be done for anyone not enrolled prior to incarceration. This will require collaboration between the county correctional facilities and the county agencies making determinations of eligibility. The proposal currently leaves these efforts up to counties to figure out without clear state guidance or oversight, and we recommend that the proposal require clear and consistent policies and practices, and that designated and trained staff are assigned to carry out specific obligations. In addition, if DHCS wants to connect incarcerated individuals with managed care plans, clear processes and responsibilities must be put in place for the selection of a Medi-Cal plan prior to release. We appreciate the desire to coordinate prior to release to continue behavioral health treatment, but more details about how this process will work is needed, as currently Medi-Cal enrollment and then plan choice is a two-step process. Given the 45-day legal limit for an application to be processed, this would need to start well before release in order to ensure that people are enrolled on Medi-Cal when they leave jail or prison. And if the goal is to enroll people in a health plan, the process could take even longer. Third, we recommend that there be a clear policy of how continuity of care will occur between services provided in the facility and in the community post-release. Specifically, individuals should be connected with services and organizations in the locations they will be living post-release. And in order for this to happen, some agency or plan will need to ensure that the individual is enrolled in a Medi-Cal plan prior to release, or make an appointment with an appropriate fee-for-service provider in the time immediately post-release. Once again, clear guidelines about who is responsible for making these connections and appointments is needed. Thank you very much for the opportunity to testify. I'm happy to answer any questions you may have.
Thank you very much. That concludes this panel. I'll bring it up to the dais and see if we have any member questions. Dr. Wood?
No, I'm fine. Thank you.
Thank you. I will take a chance, if I can, to echo and elevate some of the comments from J.C. Cooper. I thought she said it quite well, that this specific population has higher rates of physical and behavioral health needs. And for us to have effective mental health and behavioral health treatment, we're going to need to intervene earlier, as it may help to prevent recidivism, to decrease ER usage, and to decrease hospitalizations. But I'd like to dig in with the department a little bit, if I could, about this last comment from NHELP about Medi-Cal suspension versus termination, and ask them their logic for why it is time limited.
So I think one of the things I would say is that we are currently evaluating the policy around suspension versus termination. I know that we've had many conversations with NHELP regarding that particular piece. I think there are some considerations we're making in regards to federal pieces that we need to evaluate closely. But I would just say the department is currently looking at that proposal at this time. Also would just note that it varies across the U.S. in regards to how states have done this, whether they suspend, terminate the suspension time periods, whether it's 1 year, whether it's ongoing, or whether it's a longer period of time. It does vary state to state. And we are also working with other states who have various policies to just inform our thinking as we continue to evaluate this moving forward.
Thank you for that. Was hoping if you could comment on the LAO's question regarding state mandate and where this proposal sits.
So currently, as in the trailer bill, we are mandating that this be a requirement statewide for release from jail, and look forward to working with sheriffs and counties to be successful in that implementation.
Thank you for that. With that, we will thank this panel very much and move on to issue 5.